A very good morning everyone. This is Dr. Singaram. So I am continuing the series of discussion of FMGE recent pattern questions. So today I will be discussing the questions in systemic pediatrics. Questions in neonatology and general pediatrics have already been done, the links of which I have shared in the description below and will be available at the end of the video. So let us get started. This question is about most common cause of pyogenic meningitis in children. Please remember, whenever they use the word pyogenic, pyogenic means refers to what? Pyogenic refers to bacterial. So, because it is causing pus, it's called as pyogenic meningitis. So, what is the most common bacteria causing meningitis in children is the question. The answer for this is pneumococci, okay, or streptococcus pneumoniae. That is the overall most common cause. Whether it's a child or an adult, overall most common cause of bacterial meningitis is pneumococci. Please note that if the question is asking about which is the most common cause in neonates, then your answer should change to E. coli. Otherwise, in all other age groups, it is a pneumococci, which is the overall most common cause of bacterial meningitis. Suppose they ask you the question about viral meningitis. Viral meningitis. Virus does not produce any pus, so this is also called as aseptic meningitis. So the question may come in your exam like this: most common cause of aseptic meningitis. Then you have to choose a virus. Now in India, what is the most common virus causing meningitis? It has been recently updated. Please make a note of it. It is JE virus. It is Japanese encephalitis virus. Whereas when you look at worldwide scenario, worldwide the most common cause of virus associated meningitis is enterovirus. Okay. Now in the question, one of the options you see is HSV, which is herpes simplex virus. Please note for your exams, herpes simplex virus is not the most common cause of viral associated meningitis, but the point to be remembered is that it is the most common cause of sporadic viral meningitis. Please note the term sporadic. Only if the question mentions sporadic, you have to choose HSV. Otherwise, HSV will not be the answer. If they are asking about virus, it is a JE virus, which is the answer. But worldwide, it is enterovirus. Okay, in India, it is JE virus. If nothing is mentioned in the question, that is India or worldwide, please choose JE virus as the answer, because you are going to give Indian exams. Some further questions in meningitis which you need to know about are: what is the classical triad of meningitis? The classical triad is fever, headache, and neck stiffness. This is a classical triad. Fever, headache, and neck stiffness are the classical triad of meningitis which you need to know about. What is the most common complication of meningitis? This is something which is differently given in different guidebooks, but answer is seizure. Please note that seizure is a manifestation as well as a complication of meningitis. Most common overall causes seizures. Most common overall complication is seizures. Followed by seizures only, you have this hearing loss. So if seizures is not given in the question, you can choose hearing loss. What is the type of hearing loss? Yes, we are talking about sensorineural hearing loss. Okay, right. So that is why one of the question also came: which of the following investigation should be done in a patient who is being discharged after treatment for pyogenic meningitis? The answer is hearing evaluation by otoacoustic emission or brainstem evoked response audiometry or BERA. Okay, that should be chosen. It was one of the previous exam question. But please remember, overall most common complication is only seizures. Most specific marker of neural tube defect. What is the answer? In neural tube defect, you know various neural tube defects, right? For example, spina bifida, anencephaly, they are all examples of neural tube defect. What is a marker of neural tube defect is a question. This is, they are talking about the antenatal markers. Okay, they are talking about antenatal markers. Okay, there are two antenatal markers. One is acetylcholinesterase, which is the second option. Third is alpha fetoprotein, which is the third option. Right? So among these two, which is the most specific marker? Most specific marker is the question. Please choose the answer as acetylcholinesterase, because even though commonly AFP is what we check for, but that is not a specific marker. It can be elevated in other conditions also. You all know that. But acetylcholinesterase is elevated only in case of neural tube defect, and hence the answer for this particular question. Right? So if they ask you specific marker, choose acetylcholinesterase. If they ask you which is the most sensitive marker, then you can choose alpha fetoprotein. Sensitive marker is alpha fetoprotein. Right? Now, you must be knowing this beta-2 transferrin. What is it a marker of? It is a marker of what? It is a marker of endogenous CSF leakage. Endogenous CSF leakage. Right. So that's about this particular question. Some further questions which are possible in neural tube defect. What is the mode of inheritance of neural tube defect? Your answer should be, it is not just autosomal dominant or recessive, it is multifactorial. It is multifactorial inheritance. Right. One of the important factors being deficiency of folic acid. You all know that. Which neural tube defect is associated with maximum viability? What is the meaning of viability? Viability means nothing but survival. So they are asking which neural tube defect has maximum chance of survival. It is supposed to be one of the benign neural tube defect. What is that? It is spina bifida occulta. Spina bifida occulta. What is the meaning of occulta? Occulta means something which is hidden inside. It is hidden inside, not visible outside, and also there is no problem to the spinal cord or meninges. So that is why this condition, spina bifida occulta, is supposed to be associated with maximum chance of survival. Right? Okay. Now, earliest neural tube defect, NTD means neural tube defect, to be identified on antenatal ultrasound. Please remember that the defect should be very large so that it can be identified on antenatal ultrasound early. What is the defect? Yes, it is anencephaly, wherein the brain and the overlying skull are not developed properly. That is called as anencephaly. So that is the earliest to be identified. Even by 10 to 12 weeks of gestation itself, you will be able to identify on ultrasound because that is a big defect. Right. So, next question is regarding prevention of neural tube defect. You all know one of the etiologies of neural tube defect. What is that? Folic acid deficiency. So, that is why in the prevention, folic acid supplementation is found to be very, very helpful. What is the dose of folic acid? They commonly ask in your exam. In a normal pregnancy, the folic acid dose is 400 microgram every day. But in a previously affected child, but if the mother has previous affected child, then the dosage of folic acid is to be 10 times more in the next pregnancy. How much? 4000 microgram daily. That's what you need to remember. Now, one more important point to be emphasized here is folic acid to prevent neural tube defect. It should be started very, very early. Okay, because neural tube is formed by 3 to 4 weeks of gestation. Folic acid also has to be started before the time itself. So that is why it is said that the supplementation of folic acid in pregnancy is called as periconceptional folic acid supplementation. That means what? Around the time of conception itself, you are going to provide folic acid. This is called as periconceptional folic acid supplementation. Right. Next is a question asking about SSPE. This is one of the recent exam questions as well. Is associated with what condition? Answer is what? Yes, it is a long-term complication of, it's a long-term or a chronic complication of measles infection in childhood. Right. So what is this SSPE manifest as you all know that SSPE is subacute sclerosing. Okay, I'll just write it, subacute sclerosing panencephalitis. So it is associated with problems in the brain in the form of seizures. And they can ask you this question, what is the commonest type of seizure which occurs in SSPE? It is myoclonic seizures. Number 1 is myoclonic seizure. Number 2 manifestation is that it would be a school-going child who would present with the complaints of deterioration in school performance. The child may not be studying well, like he used to previously study well, now he is not studying well. So deterioration of school performance is also one of the other classical features of SSPE. Okay. For your exams, measles is one of the very important topics often asked in your exams. As I keep saying, measles is not just known for its fever, rash and all. Measles is known for its complication. The long-term complication is what I have discussed. Suppose I ask you a question, which is the most common acute complication of measles? What is your answer? Your answer is going to be, this is also one of your previous questions. What is the answer? Answer is going to be otitis media. Please make a note of it. It is otitis media and not pneumonia, as some of the guidebooks wrongly give. Most common acute complication is otitis media. Right. This slide is a very, very important slide for your exams. They ask you about associations of congenital heart disease, okay, with some important genetic syndrome. This is very, very important. Repeatedly questions are coming on this. Almost every year one question is from this slide itself. Okay, right. Let us see. First question is about Down syndrome. What is the commonest association? It is called as a cushion defect, or what we call it as an endocardial cushion defect. So what is this cushion defect? Cushion defect means a combination of atrial and ventricular septal defect. So I am just writing as AV septal defect. AV septal defect is atrioventricular septal defect. What about in Turner syndrome? Turner syndrome is associated with, yes, the most common is not coarctation, it is bicuspid aortic valve. Most common is bicuspid aortic valve. The next is coarctation of aorta. If bicuspid aortic valve is not given in the option, then you can choose coarctation of aorta. But if it is given, bicuspid is the most common, right? Now, aorta means something like on the left side. So I remember like this, Turner syndrome is associated with left-sided heart lesions. Left-sided heart lesion. Whereas when we talk about Noonan syndrome, it is associated with right-sided heart lesions. What is on the right side? Right atrium, right ventricle and pulmonary. Yes, the most common association is pulmonary stenosis. Pulmonary stenosis. That's what I want you to remember for Noonan syndrome. Okay. Then comes a very important intrauterine or a torch infection called as congenital rubella syndrome. What is the most common heart disease? The most common heart disease is PDA or patent ductus arteriosus. Many times repeated question. Right. Then comes a question on infant of a diabetic mother, which is the most common congenital heart disease. Your answer is going to be VSD. There is also one more question. They can ask you sometimes most specific congenital heart disease for infant of a diabetic mother. Then it is TGA, which is transposition of great arteries. But that is not usually asked. What is commonly asked is most common heart disease. It is VSD. Next is a very simple question asking about which of the following is a cyanotic heart disease. The answer is PDA, patent ductus arteriosus. The answer is patent ductus arteriosus. You can remember the acyanotic heart diseases like this. Suppose this is the outline of the heart which I am drawing and the blood vessels which are originating from the heart like this. So this is left atrium, left ventricle and aorta on this side. This is right atrium, right ventricle and pulmonary artery on the other side. You can have some communication which is what are the acyanotic heart disease. For example, what is this communication? Yes, it could be atrial septal defect because it's a defect between two atrium, okay, and atrial septum. What is this could be? This could be VSD, ventricular septal defect. Then there could be a communication between the aorta and the pulmonary artery like this. What is this? That is what is the, that is called as PDA, patent ductus arteriosus. So these are examples of acyanotic heart defect. Tetralogy of Fallot, TGA, that is transposition of great arteries, TAPVC, that is total anomalous pulmonary venous communication, are all examples of cyanotic heart disease. Okay, right. You should know the names of acyanotic and cyanotic heart disease, very, very important for your exams. The next is about a question on severity of cyanosis in tetralogy of Fallot is determined by this. One of the very recent exam question. Before I discuss this question, what are all the components of tetralogy of Fallot? The 4 components are already given in the question. What are they? One is VSD, second is overriding of aorta, third is right ventricular hypertrophy, fourth is subpulmonic stenosis. Subpulmonary means below the pulmonary valve. What is below the pulmonary valve? It is right ventricle. The part of the right ventricle below the subpulmonary valve, below the pulmonary valve is called as infundibulum. So subpulmonic stenosis is also called as a infundibular stenosis. These are the 4 components of tetralogy of Fallot. Tetra means 4. So there are 4 components. Alright. This by itself is a question. Now the question is slightly different. They are asking you severity of cyanosis determined by what component of this determines the severity. Remember, the reason for cyanosis in case of tetralogy of Fallot is decreased pulmonary blood flow. When the pulmonary blood flow is not happening, oxygenation is basically not happening. That's why there is a cyanosis. So it is a decreased pulmonary blood flow. Now you can tell me the answer. Which of the following anomalies, the 4 problems, causes decreased pulmonary blood flow? Obviously, your answer is going to be subpulmonic or infundibular stenosis. More the stenosis, more severe will be the cyanosis. Lesser the stenosis, less severe will be the cyanosis. That's all. So that is why the answer for this question is subpulmonic stenosis. Now, because of the blood passing through this stenosed area, they can ask you this question. What is a murmur heard in case of tetralogy of Fallot? Blood passing through a stenosed pulmonary area. So what is that? Yes, it is ejection systolic murmur in the pulmonary area. Ejection systolic murmur. Okay, right. Then one more question possible in case of tetralogy of Fallot is, what is the classical X-ray finding noted in case of tetralogy of Fallot? It is called as boot-shaped heart. It's a boot-shaped heart. What is the reason for this boot-shaped heart? Reason for this boot-shaped heart is right ventricular hypertrophy. The next question is asking about feared complication of Kawasaki disease. Please note that Kawasaki disease is one of the most common vasculitis in children. What is it? Vasculitis? It's a medium vessel vasculitis. And what is the problem? What is the vessel involved in case of this Kawasaki disease? Unfortunately, it is coronary arteries commonly. That is why the complication of Kawasaki disease, and the answer for this particular question is coronary artery aneurysm. Very, very important. There are two important complications which can occur due to involvement of coronary artery. One is a coronary artery aneurysm. Second is that it can be associated with myocardial ischemia. Because of decreased blood flowing through the coronary artery, there can be development of myocardial ischemia. Okay, Kawasaki is a very important question for your exams. They can ask you which investigation is very, very important when a child is having Kawasaki disease. What will be your answer? Your answer is going to be echocardiography, because that will help in the detection of coronary artery aneurysms. Next thing I would want you to remember is what is the treatment of choice once a child is diagnosed with Kawasaki disease? The answer is not steroids, but it is intravenous immunoglobulin, IVIG. That's also a very important question for you to know about. What I have given in this slide is a very, very important diagnostic criteria. It is called as a diagnostic criteria of Kawasaki disease. Very important for your exams. You should know the features. Remember, Kawasaki disease is a disease of unknown etiology. So all the features cannot be correlated and remembered. So I will tell you an easy way to remember the features. Most essential feature of Kawasaki disease is fever for more than 5 days, without which you cannot diagnose a Kawasaki disease. Now, the others criteria can be remembered with the mnemonic CREAM, C-R-E-A-M. What is it? C for conjunctivitis, bilateral conjunctivitis, R for the rash, E for extremity. In the extremities, you can get edema as well as skin peeling in the fingers and all. Okay, skin peeling. Right. Okay. Then A stands for adenopathy, which is single cervical lymphadenopathy. And M stands for the mucosal changes. What you see in the picture, what you see is a very, very reddish tongue called as a strawberry tongue. Okay, right. So these are the features of Kawasaki disease which you need to know about. Please don't forget the most essential feature is fever. The next question also is one of the recent exam question. They have asked about wide open fontanelle with rough skin and dry skin in an infant is suggestive of which of the following? Remember, in scurvy, the classical manifestation is not this wide open fontanelle or rough skin. Instead, it is bleeding. Remember, scurvy, which is due to vitamin C deficiency, is characterized by bleeding manifestation. In fact, bleeding can also involve the bone, wherein the child does not move the limbs at all. So it appears like a paralysis, but not a true paralysis. So what is the term we use? We term it as pseudo paralysis. Very important. In rickets, I am sure that all of you must be knowing the classical features of rickets, which includes this bowing of the legs, okay, rosary, all those things, okay, bowing of the legs and rosary. It is not the dry skin, rough skin and all, bowing of the legs and then ricketic rosary. All those are classical findings in rickets. So the answer is not that. Now the last option, let me tell you the last option first. Pellagra, okay. Pellagra, the classical features are due to what? Okay, are characterized by D's. You all remember so many D's. What are they? They are the dementia, dermatitis in the sun exposed area, what we call it as a photodermatitis, and if not treated, it may lead to death also. So those are the 4 D's of pellagra. Okay, right. So the answer for this question is going to be hypothyroidism. It is going to be hypothyroidism. So what type of hypothyroidism I am talking about? It is not the acquired hypothyroidism. I am talking about congenital hypothyroidism. Okay, right. You can see that in all cases of hypothyroidism, you are going to have a dry skin. That's correct. In a baby, you have got wide open fontanelles. Not only wide open, it's also delayed closure. Delayed closure of the fontanelles also is a feature of hypothyroidism. Wide open and delayed closure. What are the other features which you need to know about in case of congenital hypothyroidism is that the baby is generally lethargic. The mother will say that the baby is not feeding properly. Okay, letharginess is one of the features. Second is that they can have this macroglossia as one of the features. Macroglossia. Next important feature which you can notice on physical examination is umbilical hernia. Umbilical hernia. What is the other feature? It is prolonged neonatal jaundice. I told you that neonatal jaundice can last for a maximum, normal jaundice can last for a maximum of 14 days. Here it will be prolonged to more than 14 days. Okay, right. Then one more feature which you can notice is there could be a delay in the passage of meconium. Normally meconium is passed within 24 hours, but in these children even after 72 hours there is a delay in the passage of meconium. All these are other additional findings which they can ask you if they want to ask about congenital hypothyroidism. Some one-liner questions in congenital hypothyroidism I want you to remember are, which is the most common cause of congenital hypothyroidism? It is not maternal hypothyroidism. Instead, it is a problem in the development of the baby's thyroid gland itself. What will you call it? You call it as thyroid dysgenesis. Genesis means formation. Dysgenesis means abnormality in the formation of thyroid gland, like aplasia, hypoplasia, ectopia, all those things. So remember the word thyroid dysgenesis. Second question, most common cause of acquired hypothyroidism. It is not iodine deficiency. Remember, it is not iodine deficiency, but instead it is autoimmune thyroiditis. What is the name of that autoimmune thyroiditis? Yes, it is Hashimoto's thyroiditis. Overall, most common cause, even in the Indian population, it is autoimmune or Hashimoto's thyroiditis. Okay, right. Next question is regarding screening test for hypothyroidism. Please remember, it is TSH. One more question. After you start treatment for hypothyroidism, which test is very helpful in the follow-up? It is again TSH. What do we look for? We look for normalization of TSH. Okay, we don't directly look at the level of T4 and T3. No. Our aim after starting treatment for hypothyroidism is to look for normalization of TSH. Screening test, again it is TSH. Now one more question possible is, when to do the screening test? When to do the screening test? It is not immediately done after birth, because at birth there may be elevated levels of TSH due to the stress of delivery. So we don't do it at birth itself. It is usually done at or after 72 hours. This is the most accepted answer, at or after 72 hours, because by the time the TSH surge and all would have come down and you will get a correct value. That's why. Right. Now the last question here, which is the most common complication of untreated hypothyroidism? You all know that if hypothyroidism, thyroid deficiency is going to directly affect the brain. So the child will develop definitely very, very low IQ. Okay. Right. Second is, the child can develop short stature. That's also very, very important complication. They can ask you this question. What is the type of short stature? Proportionate or disproportionate? Answer is going to be disproportionate short stature. What is that disproportionate? Which part of your body is more affected in hypothyroidism? It is going to be short limbs. So this is one of the classical examples of short limb short stature. This is what you need to remember. Next, I am going to provide you the revised WHO management guidelines for management of pneumonia in the community. The corresponding color coding is for a program called as a IMNCA, which is Integrated Management of Neonatal and Childhood Illness. You can see that there are three levels: no pneumonia, pneumonia and severe pneumonia. Previously there was something called as a very severe pneumonia, but in this edition it has been taken out. Okay, it is only severe pneumonia. Okay, right. Okay, now you can see that for no pneumonia it's a green color, pneumonia it is yellow color, and for severe pneumonia, please note, it is not red color but it is pink color. Very, very important. There is no red color in case of IMNCA color coding. That should be remembered. Okay, so let us see the features and the corresponding management. In no pneumonia, the child is just having fever. There may be some cough or cold, but there is no other absolute problem. Child is otherwise well. So for this particular case, if there is no pneumonia, the management should be at home. You should give only paracetamol, no other medications are required. Okay, right. Now, next is regarding pneumonia. What is the meaning of pneumonia? Pneumonia means presence of fast breathing plus or minus retractions, presence of retractions. Here again, what is advised is home management, but because this is pneumonia, you should be starting what else? You should be starting oral antibiotics as well. And as per the program guidelines, what is the oral antibiotic which should be started? Yes, it is amoxicillin. It is amoxicillin. Right. Okay. Right. Now, last one is severe pneumonia. Of course, it's a danger. So, what are the signs of severe pneumonia? Any child who is having hypoxia, in addition to any of the findings, is said to have severe pneumonia. Or the child has any one of the danger signs, any one of the danger signs, then also it is called as severe pneumonia. What are the danger signs one should look for? The danger signs one should look for are cyanosis, convulsions, letharginess, and the child is not feeding at all, poor feeding or poor drinking. Okay, these are the danger signs. Any one of these present, then it is automatically called as severe pneumonia. Will you treat the severe pneumonia in the home or in the community? Never. The child should be immediately referred to the higher level hospital. That's what I want you to remember. Okay, where they will start IV antibiotics. Now just want you to remember this one particular question. Please look at the top portion of the slide. What is the cutoff respiratory rate to be called as fast breathing? Depends on the age of the child. Suppose the child is less than 2 months, more than 60 per minute is called as fast breathing. 2 to 12 months, more than 50 per minute is called fast breathing. More than 12 months, more than 40 per minute will be called as fast breathing. Why this is very important? Because if they are going to give you a clinical question, they will tell you the features what the child is having. At that time, they will also mention the respiratory rate. Based on this, you have to decide the management. That is why I want you to remember the respiratory rate cutoff above which it can be called as fast breathing. This is a very, very important slide for you to remember. Now, just a general question, which is the overall most common cause of pneumonia in children? What will be your answer? Your answer is going to be overall most common cause. What is that? Yes, it is Streptococcus pneumoniae without any doubt. Answer is Streptococcus pneumoniae. One more question on respiratory tract infection. This was asked in a recent exam. A 9-month-old infant is admitted with respiratory distress with a preceding history of upper respiratory infection. On examination, bilateral wheeze is heard and the chest X-ray shows hyperinflation. What is the possible diagnosis? You can see here respiratory distress. Again, they are pointed to the a lower respiratory problem or a respiratory infection. That's what they are trying to tell you. Okay. Now, preceding, that means previously, before this episode, child also had an upper respiratory problem also. Okay, right. And what is the finding you are hearing? Wheezing. Okay, wheezing localizes the pathology to lower respiratory tract. Okay, something like bronchi or in the lung parenchyma itself. So, wheezing tells you that there is a problem in the lower respiratory tract. Chest X-ray shows hyperinflation. That means what? Too much of air inside the lung fields. Question is, what is the diagnosis? Is it going to be pneumonia? Pneumonia can be possible, but then wheeze is not very, very common in pneumonia, right? Wheeze indicates a problem or a pathology in the bronchioles. Okay, bronchioles or the bronchi. Answer for this particular question is bronchiolitis. It is called as acute bronchiolitis, which is one of the common conditions of infections in the lower respiratory tract. You all know pneumonia, but you should also know this classical presentation of acute bronchiolitis. How it is diagnosed? It's a clinical diagnosis which is defined as first episode of wheeze following an upper respiratory infection in a child less than 2 years of age is called as acute bronchiolitis. Please make a note of it. It's a clinical diagnosis. You don't even need the X-ray. Even the X-ray finding is given, you don't need it. The first episode of wheeze following URI in a child. Why this first episode of wheeze? Because if it is recurrent episodes, it may be what? It may be asthma itself. Recurrent episodes, it may be asthma itself, right? Okay. Recurrent wheezing would be asthma. Okay, so that is why I am just specifically mentioning first episode of wheeze. Now, coming back to acute bronchiolitis, if they ask you the question, what is the most common cause for this acute bronchiolitis? Please answer as RSV infection, respiratory syncytial virus infection. Not all children will require treatment for acute bronchiolitis, but children with comorbidities, like for example immunodeficiency, they require treatment. What is the treatment of choice? It is ribavirin. What is the antiviral medication? That was also one of the exam questions. It is ribavirin. This is one of the very recent exam questions, so I want you to remember the organism as well as the treatment, which is very well possible and can be repeated in the coming exams. Okay, right. Now just a quick question. What is this croup? Croup is an upper respiratory infection. What is that? It's combination of upper and lower, but more of upper infection. What is that? It is acute laryngotracheobronchitis, LTB, laryngotracheobronchitis. What is the organism? What is the most common cause? The cause of this croup is parainfluenza virus. Parainfluenza virus. Okay, right. So that is the approach to this particular question and some related one-liners which can be asked in future. The next question we have is a 1-month-old child presents with repeated episodes of non-bilious vomiting, excessive crying and dehydration. What is the diagnosis? This is a 4-week or a 1-month-old child with non-bilious vomiting. Non-bilious vomiting itself tells you the problem is in the upper part of the gastrointestinal tract. Excessive vomiting, and because of repeated vomiting, child has also gone into dehydration. What is the diagnosis? This is a classical presentation of pyloric stenosis. What is the correct term? What is the reason for stenosis? It is due to hypertrophy of the pyloric muscle. This is called as IHPS. What is this IHPS? It is idiopathic hypertrophic pyloric stenosis. Right. So that is why the child is having non-bilious vomiting along with dehydration. What is the other feature? What is the other features in addition to vomiting? Because of an obstruction due to pyloric stenosis, there could also be distension of the stomach. So it results in a mass in the, yes, it is a mass in the above the umbilicus. It is in the epigastric region. What we call it as a epigastric swelling. And what is the classical shape of the swelling? The classical shape of the swelling is, yeah, it's a olive shaped swelling. It's a olive shaped swelling. And one more finding you can notice is that after the intake of food, you can see visible peristalsis. So it is also called as visible gastric peristalsis. So 2 important findings they can ask you. Okay, right. Now in one of the exams the question was, what is a metabolic abnormality? What is a metabolic abnormality noted in hypertrophic pyloric stenosis? What is a metabolic abnormality due to this repeated vomiting and all? They can develop dehydration, but what is metabolic abnormality? It is hypochloremic metabolic alkalosis. Hypochloremic hypokalemic metabolic alkalosis. Metabolic alkalosis. Okay, this is a classical finding. Some of the books can also tell you one more thing, but it is not important for your exam, but just note it. Along with that, there is paradoxical aciduria. Paradoxical aciduria. Right. So this is the metabolic abnormality noted in case of this pyloric stenosis. One more question they can ask in the exam. Which is a drug associated with development of pyloric stenosis in an infant? That is why we don't prefer this drug in the first few months of life itself, because of a rumored or a probable association of this drug with pyloric stenosis. What is that? Yes, it is erythromycin. Okay, erythromycin. Okay, right. So these are the possible questions which you need to know about while discussing about idiopathic hypertrophic pyloric stenosis, a very potential topic for your exams. The next question is a very important question. Which of the following is useful in acute diarrhea? Please note the answer is going to be zinc. The answer is zinc. Only zinc among the options is helpful in case of acute diarrhea. You should also know the duration of zinc treatment. It is for 14 days. And also very important, according to the program guidelines, what is the dose? The dose is in a child less than 6 months, you are going to give 10 mg per day. And for children more than 6 months of age, you are going to give 20 mg per day. This is very important. Now, if I ask you one more question, in acute diarrhea, what is the cornerstone of treatment? What is the cornerstone or the most important part of the management? It is not treatment of a infection and all. No. It is ORS. ORS solution or oral rehydration solution. What we are now using is WHO recommended low osmolarity ORS. WHO recommended low osmolarity ORS. What is the osmolarity? Osmolarity is, yes, 245 milliosmoles per liter. 245. That's what I would want you to remember. Right. Now you should also know what are the individual components. How much is sodium? How much is potassium? All those are asked in your question. Sodium, glucose, potassium, chloride and citrate. Please remember sodium is 75. Glucose is also 75. Okay, both of them are kept in an equal proportion because in the gastrointestinal tract, sodium and glucose are absorbed together. Right. Potassium, it is 20. Chloride, it is 65. Citrate, it is 10. So altogether, it makes up 245 milliosmoles per liter, which is what you need to remember about. Now, one more quick question. Which is the most common organism associated with diarrhea? In pediatric population, it is going to be rotavirus. And diarrhea is also common in pediatric population only, right? So that is why overall also most common organism is rotavirus. Suppose they could ask you the question in a different way, which is the most common organism associated with the diarrhea in adults, then your answer will be slightly different. It is Norvac virus. It is Norvac virus. Able to follow. So these are some of the one-liners which are possible in this particular section. Next we move on to this question. What is the treatment of choice in nephrotic syndrome due to minimal change disease? I will tell you some quick one-liners in nephrotic syndrome. Next, before that, let's solve this question. Treatment of choice in nephrotic syndrome due to minimal change disease. Remember, what is that minimal change we are talking about? Minimal change we are talking about is a fusion or effacement of food processes of the podocyte. That is the minimal change we are talking about. That is the most common cause of nephrotic syndrome as well. Now remember, the treatment is always going to be steroids. Okay, we give steroids over a period of 12 weeks or 3 months, and that is the treatment of choice. Okay, now when we talk about the cyclosporin and tacrolimus, these are the treatment in case of used in cases of steroid resistant nephrotic syndrome. Suppose the nephrotic syndrome is not responding to steroid, then we can use this cyclosporin and tacrolimus. Yes, steroid resistant nephrotic syndrome. Okay, right. That is the point I would want you to remember. Only in case of resistance, not usually. Okay, right. You all know that in nephrotic syndrome, the characteristic feature is proteinuria, excessive loss of protein. So, question is called, what is loss of, what is the proteinuria to be called as nephrotic range proteinuria? In adults, I am sure all of you must have read about as more than 3.5 grams over 24 hours. Okay, that is the definition in adults. What about in children? In children, it is not like over 24 hours because it's little difficult. So we have changed to per hour measurement based on body surface area. It is more than 40 milligram per meter square per hour. Please make a note of this. More than 40 mg per meter square per hour. We should also know what is the normal protein excretion in children. It is less than 4 milligram per meter square per hour. So basically 10 times that value is what we call it as nephrotic range of proteinuria in children. Right. Move on to the next question. Which conditions are associated with congenital nephrotic syndrome? This is something which is important and one of the recently asked exam question. Okay. Even in your exam it was asked. Please note, it is due to mutation in 2 genes. One is called as a NPHS1 gene. Okay. Other one is called as a NPHS2 gene. Okay. Right. So these are the questions which can be asked. Congenital nephrotic syndrome is NPHS1 and NPHS2 gene. Okay. Right. Now, what are the features of glomerulonephritis in children is the next question. Please make a note of this. It is characterized by hematuria. Very important point is hematuria. There are so many conditions which can be associated with hematuria. But what is a hallmark of hematuria due to glomerulonephritis? It is the presence of dysmorphic RBCs. Dysmorphic means abnormally shaped RBCs along with RBC cast. So, not just hematuria is enough. You should also know what is the type of this RBC finding. That's important. Second is there will be mild proteinuria. That's also important. Third is hypertension. Okay, classical feature. Third is hypertension. Will there be edema? Definitely there is going to be edema, but there is not marked edema like in nephrotic syndrome. Here there is a minimal edema like periorbital puffiness or mild pedal edema. Periorbital puffiness. There can also be pedal edema, but commonly you get periorbital puffiness. These are the features of glomerulonephritis which you need to know about. And one last question here, they can ask you this, which is the most common cause of glomerulonephritis in children? What should be your answer? It is going to be post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. That is the overall most common cause of glomerulonephritis in children. So that concludes our discussion on recent FMGE pattern questions in pediatrics. Thanks for watching. I have also given the links of the other related videos part 1 and part 2 in the description below, as well as it is displayed here. Please have a look at it, and I wish you all the best for the upcoming FMGE exams. Thank you.